Text 3. Uterine fibroid embolization. Uterine leiomyomas are benign monoclonal tumors of the uterus composed of smooth muscle cells and an extracellular matrix of collagen, fibronectin, and proteoglycan. It is not known what initiates fibroid genesis, although it is clear that the growth of fibroids is affected by the presence of estrogen, progesterone, and a variety of growth factors. A role for gonadal steroid is suggested by the fact that fibroids are not seen in children and tend to regress after menopause. As they grow, fibroids cause enlargement of the uterus. Fibroids that are located in a submucosal position, as well as intramural fibroids that abut the endometrial lining, are associated with heavy menstrual bleeding, whereas the presence of large fibroids or the overall enlargement of the uterus is associated with local pressure, pain, or compressive effect. Most fibroid tumors receive their blood supply from the uterine artery. Perfusion from the ovarian artery is seen in 5 to 10% of cases. Anastomoses between the left and right uterine arteries occur in about 10% of patients, and between the uterine and ovarian arteries in 10 to 30%. The tumor is typically surrounded by a dense arterial plexus, whereas the center of the fibroid itself is relatively hypovascular. Uterine fibroid embolization is a percutaneous procedure that results in the occlusion of the perifibroid vessels and ischemic infarction of the fibroid. The treated fibroids shrink over the course of several months to years. As a result, symptoms associated with the presence and growth of the fibroids is reduced. Incompletely infracted fibroids may increase in size again. New fibroids may also develop over time. However, in general, a successfully treated fibroid will be permanently devascularized. The studies have shown that menorrhagia is improved in 85 to 95% of patients, and similar rates of improvement have been noted with respect to pelvic pain, pressure, and urinary symptoms. Treatment for uterine fibroids is generally indicated only when symptoms are present that are severe enough to be unacceptable to the patient. There is no evidence that women with no symptoms or with mild symptoms benefit from intervention. Exceptions may include women with severe anemia or with hydronephrosis due to ureteral obstruction. Medical therapy is useful in some patients with symptomatic fibroids. Acetaminophen and nonsteroid anti-inflammatory drugs, NSAIDs, are often effective for the relief of pain associated with fibroids, although these drugs do not reduce bleeding. A variety of hormonal therapies, including androgenic steroids, mifepristone, and gonadotropin-releasing hormone agonists and antagonists, have been shown to reduce uterine volume and bleeding. However, most of these treatments have not been evaluated in randomized trials. And in many cases the benefits of hormonal therapy do not appear to be sustained over the long term. In addition, many patients do not want to consider taking hormonal therapy or do not tolerate it well. For patients requiring interventional treatment, the principal current options include hysterectomy, myomectomy, endometrial ablation, when menorrhagia is the primary indication and endometrial anatomy is appropriate, and uterine fibroid embolization. Selection among these procedures depends on the patient's age, symptoms, coexisting conditions, and reproductive plans, as well as the specific characteristics of the fibroids. A thoughtful discussion of the options with an experienced specialist is essential in choosing the most appropriate treatment for a given patient. Uterine fibroid embolization is a reasonable option for most patients in whom intervention is considered to be appropriate. There are few contraindications to uterine fibroid embolization. Pregnancy, suspected pelvic cancer, active infection, or indeterminate endometrial or adnexal abnormalities requiring further evaluation and clear contraindications. The procedure may be performed in many patients who might be poor risks for surgery, including women who are obese, those who have had previous pelvic surgery or other major coexisting conditions. All women should undergo a thorough gynecologic evaluation and pelvic examination before the procedure. In addition, imaging of the uterus by ultrasonography or MRI is necessary to evaluate the size, location, and number of fibroids. Laboratory tests that are performed before the procedure typically include a complete blood count, coagulation studies, and metabolic panel, and a pregnancy test. The procedure is a percutaneous angiographic technique performed in a radiographic suite with the use of video fluoroscopic imaging. The patient is usually sedated during the procedure. A small-bore primary angiographic catheter is inserted into the common femoral artery and is advanced with the use of a guide wire over the aortic bifurcation and into the opposite hypogastric artery. The primary catheter or a smaller bore microcatheter placed through the primarily catheter is then advanced into the uterine artery and typically placed in the distal transverse artery. An arteriogram is obtained to visualize the anatomy of the arterial plexus supplying the fibroid. Embolization is then performed with the use of particulate embolization material. The embolic material is injected and is carried by the arterial blood flow to the vessels feeding the fibroid. These vessels are preferentially occluded since they are larger and have a higher flow than normal myometrial branches. The procedure is terminated when the fibroid blood supply is occluded but there is still sluggish flow in the uterine artery. The catheter is then moved to the ipsilateral hypogastric artery. And the procedure is repeated in the opposite uterine artery. After the procedure, the patient is usually admitted to the hospital for one night, for observation. Often on a designated interventional radiology service. For several hours after the procedure. Most patients have moderate to intense pelvic pain that requires treatment with intravenous narcotics and NSAIDs. Patients also typically have malaise, fatigue, and myalgias for several days. About a third of patients have a mild fever, with only 2% having a temperature of more than 38.5 degrees Celsius. Most patients return to work and other normal activities within 7 to 14 days after the procedure. Scott C. Goodwin, James B. Spies. Uterine Fibroid Embolization. The New England Journal of Medicine, August 13, 2009, pp. 690,694.